Assalamu alaikum. Mr. Omar Deva. How are you?
Yes, I'm fine. How are you?
Doing great. Alhamdulillah.
Happy to be part of this.
Welcome.
Malik, Dr. Njai, how are you?
Mr. Ba, it has been a long time, huh?
It has been a long time, man. You have a brother who lost.
Yeah, I said that you have really lost weight. I think his connection is not that strong.
Yeah.
Hello.
Deva, you're disconnected.
How are you? Are you okay?
Hello, can you hear me now?
Yeah.
Yeah.
Okay. I think we will be starting in the next 5 minutes because Brian is trying to send the links. Am I audible?
Yeah, right now is okay.
Okay.
Sadiba,
Yes.
how are you?
Who's that? Aliu?
Yeah,
I'm doing fine. How are you doing?
I'm good. I'm trying to test your network.
Yeah. How is Darbaida?
Alhamdulillah, boy. Everyone cool, boy.
Good. I'm using a mobile phone. It's disturbing around. Yeah?
Okay. Are you calling Rabah or Fez?
No. I'm in setup Sims on Wednesday. Is that Fatumata? Fatumata, how are you? How is Marrakesh? I hope you are hard on it.
So can we? Are we supposed to start now,
So
Mohammed?
can we? Are we supposed to start now, Mohammed? Yeah, I wanted to
Yeah, I
confirm from the
wanted to confirm from
technical
the
team before we start.
technical team before we
But
start. But
so I'll be hosting the
so I'll
program
be hosting the program
together with Albert.
together with Albert.
Albert, you can say hi
Albert, you
to
can
your
say hi
friends
to your
before we
friends
start.
before we start.
Hello everyone.
Hello everyone.
Dr. Malik Njai, how are you?
Dr. Malik Njai, how are you?
Aliu Cisse,
Ali Cisse,
Muhammad yourself, and Fatima
Mom
Njai. How are you all
Fatma
doing?
Lanjai, how are you all doing?
Doing well.
Oh, yeah.
Alhamdulillah.
Great.
Okay, so if everything is set, we can just start the program. Before anything, I would like to greet you all by saying Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. I hope you all are doing well. Am I audible?
Yeah.
Yeah. I just want to take this moment to ask each and every one of you, how are you doing? Like physically, mentally, spiritually, and yeah. If you're doing well, I just hope and continues I hope that it continues. And if you're struggling in any of the aspect, I hope that you get back to your feet. So without any further ado, I would like to welcome you all to the second episode of the Gasam breast cancer panel discussion. And today, I'm so excited to be here together with my brother Albert to be hosting this program. And I'm also very excited about all the amazing conversations that we are going to have today. I'm looking forward to learning so many things concerning breast cancer. So I am Mamad Jase, as some of you might already know. If you don't know, I'm Mamad, and I'm a fifth year pharmacy student at the Faculty of Medicine and Pharmacy of Rabat. And joining me as a co-host is Mr. Albert Gomez. Mr. Albert is a final year life science student at the faculty of
Science.
at the faculty of science at the University of Mullah Ismail in Mednes. So, Albert, you can send your introductory message, and you can start the program by introducing our panelists also. So, you have the floor, Mr. Albert.
Uh, Good afternoon, everyone. As Maman rightly said, I'm Albert Gomez, a final year life science student, and I'm his co-host for today's program. And I can't wait to learn from all of you, our noble panelists. Thank you all.
Thank you so much, Mr. Albert, for that brief introductions. And how are you feeling? I hope you're doing good. And I know you're looking forward to learning so many things from the panel discussions. So, without wasting much time, I would like to introduce the panelists, each one of them, by starting with Dr. Malik Njai. Dr. Malik Njai is a third-year cardiologist resident at CHU Ibn Rus of Casablanca. He got his doctorate degree in general medicine from the Faculty of Medicine and Pharmacy of Casablanca in 2018, and he's now working as an emergency doctor uh, at the at the CHP Al Hassani in Casablanca. Dr. Malik Njai, we're so glad to have you here, and we're really looking forward to having an amazing conversation with you. If you have any introductory message, you can, just forward it so that the audience will know that you are present with us. Thank you.
Good evening, everyone. Thank you very much for this invitation. I think I'm very happy since we are introducing a very important topic that everybody should know about, not only for the doctors but for the population at large, so that the prison charge, how would I say it, if like the treatment and like the coordination between doctors and patient will be much more easier if patients they know what is wrong with them, and if the population also know about breast cancer and know when to go for screening. So it is very important, especially in the Gambia, as most of the population is not that educated. So we need to educate them in a simple way, so that they will make our work much more easy. And at the end of the day, we can do much more research to make treatment of breast cancer much more easy, which comes out with a good prognostic at the end of the day. So thank you very much, and I will thank also Mr. Aliu Cisse for accepting also the invitation to join me so that to talk about this breast cancer. I'm a cardiologist, so I know that not much about it, but since as a general doctor, everybody should know the basics. But as of now, right now, I'm the one that is at the head at the cardiologist department that is running the cardio oncology department. So we have like patients that have breast cancer that we used to treat, and we used to follow them like on the basis of heart problems. So I think at the end of the day, we will know, we will get through all the things that we have to know, the basic things. We are not going to go into details, just the things that everybody should know about. And at the end of the day, it is the job of the doctor to take care of all the details and look for the best solution for the patient. But anyway, thank you very much.
Thank you so much, Dr. Malik, for that brief introduction, and thank you also for mentioning that the specialities that you are, and then also highlighting the fact that we're going to address all the common things that people need to know about breast cancer. So we're really looking forward to having an educative conversations that will be centered around breast cancer. So, without wasting much time, I will go ahead and introduce the second one panelist, who is no other person but Mr. Omar Jiba. Mr. Omar Jiba is actually a medical physicist. Um, After his French classes, when he came to Morocco, he studied radiology in Fès at the Institut Supérieur de Profession Infirmerie et Technique de Santé. He graduated in 2020 and got admissions for master's degree in the same year to study medical physics at the Institut Supérieur des Sciences the De La Sante under Hassan Premier University in Setat. He graduated in June 2022 as the first Gambian medical physicist in the Kingdom of Morocco. Omar also participated and still continues to participate in the activity organized by Gasam. He was a member of the G3 in 2018 and also served as an advisor in 2019. Mr. Omar Diba, we are so glad to have you here. If you have any introductory message to 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 verbalize, we can go ahead and verbalize it so that the audience will know that you are around, and we're looking forward to having an amazing conversation with you as well. Mr. Omar. Okay, it seems like Mr. Omar Diva is having some technical issue, but I hope he will be joining. He will be joining us shortly. So, Mr. Albert, you can go ahead and introduce our third panelist.
Okay, good afternoon and good evening, everyone. Our next panelist is Fatoumata Njai. Fatoumata Njai is a fifth-year medical student at the University of Kadi Ayat, Marrakesh. Yes, she's currently pursuing her studies in order to become a medical doctor, and hoping that she will give us some of her little knowledge about cancer, and we can't wait to learn from her. And can you please tell us something?
Thank you so much for
Okay,
that.
sorry. Before you add, Miss Fatima Tanjai, as Albert already said, is a fifth-year pharmacy, medical student. Sorry, at the Faculty of Medicine and Pharmacy in Marrakesh, and she's also actually the real representative of Marrakesh. So yeah, we're glad to have you, Miss Patjai, and we're looking forward to learning from you.
Thank you
Can
so
you
much.
give your introductory message before? Uh, thank you.
Good evening, everyone. Like Dr. Malik said earlier, we are here to sensitize people and raise awareness about breast cancer. So we are here to give a basic knowledge and how they can go and treat themselves if they realize that they have some of these symptoms of breast cancer. So thank you so much.
Thank you so much for that. Um, yeah, the fourth panelist, Miss Albert, you can go ahead and introduce the fourth panelist before.
And the last panelist is Mr. Aliu Cisse, a fifth-year medical student at the Faculty of Medicine and Pharmacy in Casablanca. Mr. Ali was the ex-V-Rep of Casablanca, and he's also a member of the Gasam football team. Mr. Ali, you are welcome. And can you please tell us something about yourself?
Good evening, everyone. My name is My name is Ali Sise. I'm a fifth year medical student studying at this Faculty of Medicine and Pharmacy, Casablanca. And thank you so much. It's an honor to be part of this platform. And I will be sharing the little knowledge that I have learned so far concerning breast cancer and the basics that like everyone should know as far as the public is concerned. Yeah, so thank you so much.
Thank you.
Thank you so much,
Hello, guys.
Mr. Aliu Sisi.
Can you hear from me?
Yeah, yes, we hearing you right now.
Sorry that my phone is just messing up. I don't know.
It's okay. Thank you so much, Mr. Alusisi, for that brief introductory message. We're looking forward to having an amazing conversation with you as well. So let's go back to Mr. Omar Diba. Mr. Omar Diba, can you please give an introductory message about yourself and also what are the what you are looking forward towards this panel discussion? So the floor is yours, Mr. Omar Diba. So the floor is yours, Mr. Omar.
Thank you, Mr. Chairperson and members of this great panel. I am honored to be part of this great topic. I have no doubt that at the end of the program, we will achieve something fruitful, for our community and humanity at large. So I am very, very, very glad to be with you. So can
Thank
you hear me?
Yeah, we're getting you.
Okay, it has been introduced. I did radiology, radiographer in bachelor's. So I also did master's degree in physics. So currently on interns in Rabat. So I'll be here to answer questions related to the equipment, the machines, and also radiotherapy, maybe medicine, nuclear, and radiology in general, inshallah.
Thank you so much, Mr. Omar Diva, for that brief overview of what you're looking forward to this program, and we're glad to have you here. So, I will just remind the general audience about the history of breast cancer. As you already know, October is here, and that means that breast cancer awareness month has been going on since the 1st of October, and that got us thinking how this month falls in this October. And this month has been associated with pink. As you can see, I'm already wearing pink, and there's been pink display going on on social media and everywhere. So it's better that people know how this history of breast cancer come about. So breast cancer awareness month is an annual international health campaign organized by major breast cancer charities every October to increase awareness of the disease and to raise funds for research to its cause, its prevention, diagnosis, and cure. So this event started as a national breast cancer awareness month in America in October 1985, something like that. And it was a partnership between American Cancer Society and the pharmaceutical divisions of imperial chemical industry to promote as the most effective tool to fight breast cancer. Breast Cancer Month is a chance for all people, both men and women, to take time and acknowledge those men and women whose life has been affected by breast cancer. So it has been 3 years since Gasam has been engaged in this breast cancer awareness, and I think we're making or we are contributing our little part that we as a student can do, organizing panel discussions, um, publishing posters about breast cancer, writing messages um, about breast cancer all over the month. And when you go to the social media platform, you can see the great work that we are doing as international students. And I hope that other international students will learn from us to also take part in this health campaign, because at the end of the day, it's these little things that matters. So we contribute in our little ways by organizing panel discussions, um, publishing um, publishing postings about breast cancer. So basically, that's it. And if any of the panelists has anything to add about the history of breast cancer and also words of encouragement towards what Gazam is doing before we get into details, it would be great. Otherwise, you can just jump into the panel. If you guys have anything to say, you can just, yeah. Okay. Mr. Albert, you have anything to add on that? Your mic is muted.
Not actually. I believe you said it all. And I think other international students will also learn from us because breast cancer is something that is worldwide. So we can fight it together through sensitization sensitization and through having some discourse on which we are doing. And yeah, that's all I have to say.
Thank you so much. You can go ahead and open the panel discussion, Mr. Albert. Yeah, by we're going to carry out the panel discussion in the form of question and answer, and that will make it more interactive. And we'll be receiving questions from the audience. If they have any questions, they can be free to write them down, and then we'll be reading it from there. So, Mr. Albert, you can go ahead and open the panel.
Thank you, Mr. Mamad. First of all, ladies and gentlemen, we start with the first question, which states, what is cancer in its simplest definition if we are to explain it to a non-medical personnel? The question is for you, our humble panelists, please.
Okay, thank you so much. Yeah, Dr. Malik, you can go ahead as the
Thank
first
you very much.
panelist.
It's a very important question. What is cancer? Well, a simple definition is that when we talk about cancer cells, these are cells that already are on in the human body. But these cells, they normally, the cells of the body normally regenerate. Sometimes the cells will live for some amount of time and they will die. But if we have those cells been producing in an abnormal way, that means that they are growing very fast or they are producing very fast, and you don't have an equilibrium between production and that of um, degradation of the cells. That is how this cancer used to start. Normally, it starts with simply a tumor that is in a localized region. It will be growing fast, getting bigger. But when we talk about cancer, it's different from tumor because cancer it spreads. Cancer it spreads. That is the difference between cancer and tumor. These are the cells of the body, but the cells of the body that cannot be regulated by the body, so it will overgrow at the end of the day, causing nuisance to the body. So that is a very simple definition of cancer: is that these are abnormal cells that grow very fast and cause nuisance to the organism. And I would like to throw a light in something that you just said about like breast cancer. When we talk about breast cancer, it's very important to know that it is the first cancer or is the most frequent cancer in women and the second cause of cancer in the whole world if you consider all other cancers. The first cancer is the lung cancer and then you have the breast cancer. So that was the thing that you have to state it in the introduction when you're talking about like the epidemiology of cancers in general. So that is simple. Cancer is an abnormal growth of certain tissues in the body, being the breast or other organ.
Thank you so much, Dr. Malik, for that brief definitions of cancer. So we can go ahead and you know to having an we want to know like in details what breast cancer is really. So Ali, if you have um, if you were to explain to a non-medical person what breast cancer is, what would be the the thing that we will say?
Actually, like just what Malik said, like it's just gonna come from the definition of like cancer cells, like cancer itself. It's like you have like these are cells, that are unregulated. It's like they are multiplying and dividing in a way that cannot be controllable. Like you get it. Like our mechanism, our cell, like our body mechanism, like cannot be able to control them because normally, like when we talk about this type of cells, like every day we have billions of cells that die and they get replaced. So these are cells that they have escaped, like they refuse to die. You get it? It's like because normally we have what we call apoptosis. It's like programmed cell death, and these are cells that have escaped that mechanism and other secondary mechanisms. So they become they become like nefast, like they become harmful to the body. So when you're gonna talk about like how to call it, breast cancer, it's a similar type of type of like cells, that are multiplying in an uncontrollable way, and it's like they are localized within the breast cell. So if it is within another organ too, it's the same thing. It's like the same thing, but these are cells that are multiplying in a way that is like unregulated, and they are dividing in a way that we cannot like that are not controllable. So within the breast, like the breast tissue or the breast organ, and they can
Okay,
actually
thank
and they can actually, how to call it, they can actually they can actually move, or make, how to call it, they can actually like move to other organs, if not like, because cancer cells, that's what actually they are like, they multiply in an unregulated way, and they can spread to other organs or other like tissues.
okay. Thank you so much for those for highlighting all of those points. I think from there we will get to we will get the grasp of what breast cancer really entails. So, Miss Fatima Tenjai, could you please emphasize on the signs and symptoms of breast cancer? Yeah, thank you.
Thank you so much. When we talk of the signs and symptoms of breast cancer, first of all, as individuals, we have to know what the normal is in our body. You have to really know your body. So there are different types of there are different symptoms of breast cancer. One, when you have a flaky skin in your body, like you have, for example, there are abnormalities in your body. So you have to stand maybe in a mirror or do regular. I'm, hello,
Yeah,
sorry about that. So
it's
like
okay.
I was saying, you have to really know your body. So for example, you could observe when you observe dimpling in your body, an inverted nipple. For instance, your nipple, instead of it to stand forward, it goes inside. That is a sign of that is one sign of breast cancer. And also, when you have flakes or redness in your breast, that is also a sign of breast cancer. And irritation or pain in your breast. So these are some of the signs of breast cancer. And when you have nipple discharge, it can be blood or fluid. Yes. Yeah.
Okay, thank you so much, Miss Fatima Tenjai, for highlighting the signs and symptoms of this breast cancer. So, Mr. Albert, do you have any other follow-up questions or preceding preceding questions that you can raise?
Uh, the other question is, what is the difference between cancer patients in different parts of the world? I repeat, what is the difference between cancer patients in different parts of the world?
Okay, can I pick that question? When you talk
Yes.
about the difference between cancer patients in different type of the world, we are talking about the most frequent type of cancer in each and every region. So it is based on the region and the way of life of those people, their culture, their economic background. That is the way we can have this cancer much more frequent in this region and not frequent in another region. If we look at in the Western region, we can see breast cancer, but it's much more frequent in like in the European and in the American region because they have a high way of living and people live longer for them to see those cancer patients than our own population. Because if you look at the life expectancies in Africa, if I look at West Africa, especially in the Gambia, the life expectancy does not go above 55 years. And most of these patients are diagnosed around this time. So you can see that even if we have a percentage of breast cancer in our population, we cannot compare to those people that live longer. So it depends on the factors, the environmental factors, the genetic factors of the individual before we can know that this kind of cancer is much more important in this region than the other region. And we have to be careful of certain things. We use the word cancer every time, but let us be careful of that, because if you say cancer, that means it's a malignant tumor. Because always we used to tell patients that if they have mass, they have cancer. That is not the case. A tumor is different from a cancer. A cancer is already malignant. That it means that it is something that grows very fast and spread very fast. But a tumor is just something that is localized and does not harm the individual that much compared to cancer. So difference of cancers in a country and another, it depends on the population background.
Thank you, Mr. Dr. Malik. Yeah. Does anyone of the panelists have something to say about that?
Generally, what I just wanted to ask something about what doctor was saying. Like actually, what he was trying to say is like we have what we call in medicine, we have epidemiology. It's like that is like in respect to a particular country like or region, we have the study of epidemiology. Is to kind of study about like the most cancers, like the cancers that are most commonly the most common, and how to call it like the age rate, like the age like the age that is normally affected, the gender and stuff like that. That's what he was trying to say. So you can go to certain areas whereby like breast cancer is one of the like the cancer that is mostly like mostly common there, and you can go to another region, you have like cervical cancer that are. So that is what he was trying to say. In general, we call it like epidemiology. In general, that's what he was trying to say.
And I would like to add too, in certain areas, we have what we call cultural barriers. So some people, some communities or individuals, the way they perceive or breast cancer will be different from a certain community. For example, their trust in medical professionals. Some individuals when they see these signs, they will rush. But in other communities, it will be different because of lack of trust and some of these stigmas they also have. So these are some of the cultural barriers that also affect one community from the other.
Okay.
Oh,
And
thank you
also,
so much for
Thank you so much
highlighting
for
all of those.
highlighting all of those.
Mr.
And
Omar, you have
I would
something to
like,
add?
Mr. Omar, you have something to add? Yeah, I would like to add something important. That is the when the imagery medical, like the way to diagnose. In certain like if you look at the European countries, they are developed. They have better equipment to diagnose their patients. But when you come to other part of the world, we don't have mammography. We don't have ERM. It's difficult to diagnose cancer. People may be living with cancer cells, but then there's no way to diagnose them. And I also think the other thing also is la mode de vie, the way we live, from our lifestyle, of the way we eat, and everything can affect, can be risk factors.
To
Okay, thank you
buttress
so
on that
much.
point, before you
Yeah.
go to the other question, is that
O-
what Mr. Ba was saying is very important. As right now, I'm concerned with my own country, like in the Gambia, like the attitude we have to change it. We have to change our attitude, because the way the country is going, we have a bad attitude towards going to the hospital if you have certain problems. I think you should not wait until at the end, at the terminal stage, you go to the hospital and start blaming doctors of their incompetency. So if you have any signs, anything that would disturb you above the normal, and you know that this is with me and it is not something that is normal, you can kindly go to the nearest hospital to complain to a doctor, so that they will see what to do for you. Because the earlier they diagnose a problem for you, the better it can be treated well. But you cannot come to the hospital at a very terminal age stage, and you think that you can do miracles. Just to know that the breast cancer is a cancer that can spread very widely, and to control it is very difficult. So if you consult early, it will be better for the doctor and it will be better for the patient. So I want to tell the population that too, if they have any problem, let them not hesitate to go and consult the doctors.
Thank you
Okay.
so much for those highlights. They are really important. most of the time, the problems that we have in Africa is lack of, awareness and less screening, and also the social stigma, as you already mentioned that. So we really, we doing things like having panel discussion and also sharing posts to make sure that we have less, we break the gap between the stigma that is existing in our different countries in Africa, and also create more awareness, and also try to get more people go for screening, because it's very important, and we'll have to decrease the cancer, the breast cancer rate in our various country. So there was a presentation of some of the signs and symptoms of breast cancer, as already highlighted by Miss Fatma. So there is a question that always come, that like is a common question. We already know that lumps in the breast is one of the most common presenting symptoms. So are all of those lumps in the breast cancerous, or not all of them? If you can highlight on that, it would be great. Thank you.
Dr. Njai will
Are
give
all
you the
lumps
Mohammed, I would
in the
love to.
breast? Yeah.
Not all. Well,
Uh,
no, not. Can I go? No. The
yeah,
answer
go
is
on.
no. Not all lumps cause breast cancer, or not all lumps are breast cancer. For instance, in women, we have what we call fibrocystic changes. These are changes. These are lumps that normally form during our menstruation. They are tender, and not flaky. So these normally disappear after a few days, maybe 5 to 7 days after your menstruation. So these are normal lumps in your breast. And also we have what we call the fibroadenoma, I guess. So these ones are solid ones, and they are different because they can move. They are palpable also. When you touch them, you can feel it, and they can move. So not all lumps are breast cancer. In women, during our menstruation, we can feel that our breast is tender, and when you touch your armpit, you can feel the lumps inside of your in your breast. So these ones are normal. But the question is, after 5 to 7 days, when you do your maybe monthly cell breast examination, and you still find that these lumps are available, they are still there, maybe that is a sign of alarm. Then you can go and seek medical attention. But the answer is no, not all lumps are breast cancer. Thank you.
And can I come in, please?
Yes, Mr. Omar, you can.
Yeah, I mean, apart from the like Fatimata said, apart from the fibrosis, I think younger women, naturally, they do have a denser breast than older women. So if you do a radiation, a mammogram, you may find cyst. We have solid cysts and fluid filled cyst. So that's where the echography comes in. So if you find a cyst, in a mass in your breast, so not all masses are cancerous. So others are in. So that's why we need to do an echography to you know to ascertain whether it is fluid filled or it is solid in nature. So it's not only the fibroadenomas, or we have also the cyst and other type of masses.
Okay, thank you so much, Mr. Omar, for
Just
highlighting
to
that
buttress on
point.
that
Okay.
point a little bit, see, lumps are not always cancer. That is true, but let's be careful because sometimes some people you can find them have cancer without any risk factor that is known. That is one thing. What is the thing that is behind it is because of the menstrual cycle of the woman. You are talking about the hormones. That's why you have the estrogen and the progesterone. And the estrogen is known to cause like increase in cell development, like means rapid multiplication. And it is one of the hormones that is incriminated in breast cancer. So a woman in a young age, like adolescent, you might be thinking that it's a fibrocyst. Fibrocyst is okay. Fibroadenoma is okay, but this fibroadenoma, if it repeats or it becomes atypical, it can become a breast cancer. So all these things is important. When you feel something that is abnormal, within a lump or anything on the breast, you have to go for screening. At least a mammograph will be done, as Mr. Bass said. There is a difference between the mammography and the echography. When you have your mammary glands that are very dense, that means that they have much more glandular tissues and they have much more fibrous tissues. That means that they have less fatty tissue. They become dense. And the problem is that when you do screening with mammography, that can give you a false positive. That is a problem. So you always have to go for echo mammogram, so that it will help you to show much more of these lesions, either whether they are benign or they are malign. So it's very important, especially in young subjects. Sometimes it's just sometimes benign, they will give you hormonal treatment and it goes away. But that should not stop the person from like consulting when he sees other signs coming up.
Thank you so much. Thank you so much for those wonderful, for those educative points. Because at the end of the day, these are these are some of the common questions that people will be asking themselves: lumps, are they all cancerous or not?
Um,
So
yeah,
yeah,
I wanted to
Ali,
add something. I wanted to add something. That's why you may see normally we use the term neoplasy. It's like a mass, like because like the mass can be it can either be like like a benign tumor or it can be cancerous. That's why normally we are not jumping. We don't always jump like any mass we say is a cancerous type of mass. So we normally use maybe a neoplasm. That is the term that is normally used. Then because that is like it can either be benign or it can be malignant. When it's malignant, that is what we normally consider it to be a cancerous type. And the best, like the most definitive way to diagnose a cancer is like by biopsy. We can do like echography, mammography, but Allah found like the last thing that's the best way to diagnose it is through biopsy. That is what we want to talk about treatments, how to call diagnosis later. So that's what I wanted to.
okay, Mr. Ali, can you please highlight us on can you please emphasize about the risk factors of breast cancer before we move to the treatments?
I didn't get what you said. The network broke.
Could you please highlight the risk factors of breast cancer? You highlight them so
Okay.
that the audience will get to know them.
Yeah, like the risk factors. Normally, in as far as cancer is concerned, we talk about risk factors. We don't actually talk about causes in general when we talk about cancer. We talk about risk factors, and one of the risk factors of breast cancer is how to call it estrogen, a hormone that is found in women. It's found in women. Like it's when you have how to call it, when you have what you call like exposure, like prolonged exposure to estrogen. This normally happens like if a person or a lady, like a girl, like has early puberty, or like she has maybe she has an late menopause. Like with that, you have a very like long period or like long period of exposure to estrogen, and estrogen. That's why in breast cancer normally we call it like hormonal dependent, because like why we say that is because estrogen is the main like hormone that is like it tends to stimulate like cancers, like the breast cancers like cells to develop more and more, like to multiply more and more. So that is the main like that is the main like the main significant like how to call it risk factor that as far as breast cancer is concerned, that you need to know. The second type also can be age. Like people that are aged like 55 and above, they have a higher risk of developing breast cancer. And as well as we have what we call like sex, like gender, like as far as female women are concerned. Because men can also develop like breast cancer, but it's very low. It's like, let me say, 1 out of 8 women will develop breast cancer, but 1 out of 833 men will develop breast cancer, because men also have a fatty like breast tissue behind the nipples, so it doesn't eliminate the fact that men cannot develop, but it's higher more in women. So as far as gender is concerned, risk factor being a female like puts you at a higher risk. And you also have like other risk factors like genetic factors or family history. If you're in a family where you have a lady, you have your mother or your auntie or family, like someone in your family that had either like how to call it breast cancer, not only breast cancer but even like ovarian cancers or other associated cancers, it can also put you at a high risk of developing this cancer. Because normally, like what happens is like there's a very like there's always like a relationship between having like breast cancer and ovarian cancers, because there are some people that can develop breast cancer. Now, when they have this breast cancer, when you do genetic tests, you can discover that they might have what we call like a mutation in the gene we call like the BRCA or BRCA2, like BRCA1 or BRCA2 gene. Like these are genes that we all have in our body. But in women who have how to call it breast cancers, we can do that test. If there is a mutation in that gene, normally there's a high risk. Like not everybody who has breast cancer will have mutation in that gene, but if they have a mutation in either BRCA1 or BRCA2, they have a high risk of developing ovarian cancers too. It's like the scenario of, I don't know, Angelina Jolie. If you know about her, like Angelina Jolie, like that was a scenario. I'll narrate about her scenario. Like what happened to her is that she didn't have breast cancer actually, but her mother had ovarian cancer. When her mother had ovarian cancer, she died out of ovarian cancer like at the age of 59. So when they discovered that, she was like, how to call it, advised to do some screening. So she went and do screening, and they discovered that she had a mutation in her BRCA gene. So when they discovered that, they proposed to her to do like to remove her breast, because there is a high chance, like 87% chance that she's going to develop breast cancer and 50% chance of developing ovarian cancers. And when this thing was proposed to her, she accepted the proposal and she did what we call like mastectomy bilateral. So that be like, how to call it, like she removed she has all two of her like breasts removed. And end of the day, what happens? He did reconstruction and with some breast implantation, so she no longer has like, normal breast. And she also did like, how to call it, ovarectomy. Like both of her ovaries were removed, so she can no longer give birth with her fallopian tubes. So these are the things, and you can also have other risk factors like being obese, like being fat, like smoking, alcohol, and the rest. But the main, like the ones that I have mentioned first, these are the most important ones. So especially like estrogen, like exposure, prolonged exposure to estrogen is like it's the main, like one of the main factors that that trigger like breast cancer.
I think I will buttress on your points also to add it that we have the risk factors. These are factors that can increase the chances of getting breast cancer. It doesn't mean that when they are there, they will forcefully give you the cancer. They will increase your chances of getting it. And some of it, Ali already said it. Family history of breast cancer. That is number one. Personal history of breast cancer. You can have cancer, breast cancer, and still it doesn't mean that you will not have another episode of breast cancer. You can have it again. Then we look at the third one is your how to call it reproduction history. It is very important, like what we know now in our society, that women getting married very lately. Normally your reproduction history, if you have like a precoce menstruation, that means before the age of 11 years or even 9 years, that can expose you because the estrogen will still be harming you. You have a long period of menopause, you have a long period of menstruation cycle. But if also you have like a menopause that is late, a late menopause, maybe after 55 years, also it exposes you. Still, we are talking about the estrogen here. And if you don't have a child before 35 years, that means you have your first child lately, also it can expose you. How? Because when you get pregnant, once you deliver, you have the prolactin hormone that will come. So estrogen will be sitting down somewhere else just to rest, and prolactin will be dealing with you. So women that are mostly not having that kind of period of rest, I will call it a resting period, they are exposed because they will only be having estrogen bombarding them. And we should know that this estrogen, what is the relationship? Is that estrogen is increases, as I said, it increases the risk of getting like multiplying cells. That is the risk of this estrogen. And the other thing is that what we are fond of right now is about alcohol and smoking. Now, women smoke a lot, they drink alcohol a lot. So, we should know about it. How increases the rate getting those estrogen hormones fire
Thank
up,
you. Okay.
right? So, alcohol, smoking, there is no really a proven scientific about smoking and breast cancer, but we can find smoking in other related cancers. That is one thing. And we have one thing also left is that we are talking about contraception. Most of our women take contraception. And this contraception, if they for a duration of more than 10 years, they can also add up to the risk factor of getting cancer. So these are the small risk factors that we find in our community, but you have other risk factors that you can find in other communities. But these are the most essential part. And people should be active. Like if you are inactive, why do they say that obesity? You are inactive, you sedentary life, you have obesity, you have a high risk of getting it because of the cell, the gracious, how do we call it, the gracious cells, the adipose cells. Also, they can stimulate the secretion of estrogen in women. So that's why it is possible for those obesity women to have that. They are classified as also risk to have that cancer. In men, we have to know that we have this kind of this gene, that is the BRCA2, because you have two of them, one and two. In men, is normally the two. And these genes, they help to suppress the growth of tumor. That's why we find it in men. Some men, they have this mutation of this gene. That's why they can develop the cancer. But it is one in 500,000 in a population. It's not that many, but they have it. The risk of men having a cancer is less than 1%, but it exists. But it exists because sometimes they can have this genetic disease associated, like syndrome de Forts, which can be a testicle cancer that is associated, can give them because testicle cancer, the most symptom that we used to see is gynecomastia. So that gynecomastia can be something that can evolve to breast cancer. So we have to be careful of all this. But these risk factors are just increasing the risk of getting a cancer. But it's not something that if they are there, they will give you 100% cancer. It's just how to control them. Especially we can control alcohol, we can control obesity, we can control smoking. So we can control, like, program our life to see that we can have our children at a very good early stage, because that will protect you much than having children in a late stage, especially for women.
Thank you so much, Dr. Malik, for highlighting all of those points. They are really important. They're essential for us to know them. And you ended your points by saying that some of them they can be changed and some of them they cannot be changed. So like we have a modifiable and then the non-modifiable risk factors. I think if Ms. Fatmata can highlight them in a precise manner, it would be great for that the audience can know like these are the modifiable and these are the non-modifiable in an enlisted manner, if that is possible. Miss
Okay.
Fatima.
Okay, thank you. When we talk of the risk factors, we can classify them into two, which is the modifiable and the non-modifiable. When we talk of the modifiable, are the factors that we as individuals we can change through our activities that we do. So the non-modifiable are the ones that we can control, that we can change. So the list of the modifiable factors are obesity, lack of exercise, drinking, smoking also, which is also a modifiable factor of breast cancer. So these activities, like we can stop smoking and stop alcohol drinking, these can change or reduce the risk of having breast cancer. And also, when we talk of the modifiable factors, we have taking hormones like hormonal therapy, and the people and the women that take oral contraceptives for a long period of time, maybe like a period of 10 years, and yeah, and reproductive history for women that, like Dr. Malik said, for women that have their first pregnancy at the age of 30, they have a higher risk of getting cancer. So they can change that. They can have, they can decide to have children below 30 years. And when we talk of the non-modifiable factors, this can lead, this actually is that these are things that we can change. For example, me as a woman, I can't change that. So being a woman is a non-modifiable factor. Um, Agent, we can't control that. You can control your agent. You can never control that. So agent, being a woman, are non-modifiable factors. And like Ali said, genetic mutations, family history. So these family history, for example, in both your mom and your dad's side, so like first degree, maybe a close relative, a family history. For example, your mother, your sister, or your daughter. So when these people have an ovarian cancer or a history of breast cancer, there is a possibility that you also will have breast cancer. And also personal history for women who had breast cancer previously are more likely to get breast cancer for a second time, as studies showed. And also, yeah, the reproductive history, early menstruation, we can change that. There are women that see their periods at the age of 9 or 10. These are non-modifiable factors, and also late menopause are factors that you can control. So yeah, thank you.
Thank you so much, Ms. Fatmata, for highlighting, for enlisting all of those modifiable and non-modifiable risk factors. So, Mr. Albert, do you have another question that you can raise for the panelists?
Yeah, I okay. From the starting, we said that there are differences between cancer patients based on their locations, and one of the factors, causing factors, we said is genetic. It's a genetic factor. So the next question is, what is there any genetic test for these cancer patients? Hello.
Uh, Mr. Omar, can you please help us on that question, please? Mr. Omar Jiba?
Yes, hello, can you hear me?
Yeah.
Yeah, these are clinical questions. I think I'll allow the doctors to go, Malik or Ali
Yeah,
or
I think
Fatima.
it is for the doctors now.
It is for the doctors
Mm.
now. Mm.
Yeah, we should know first of all there is a population to do the genetic test, and there is a population that does not need genetic test. The population that need genetic test is normally the population that have a family history, like they have a first degree parent or a second degree parent that is having this breast cancer or ovary cancer. So those who are from the first degree patients, like first degree parents that have cancer, they can be asked to do this genetic test to see their risk of having it so that they can be monitored very closely. But those people that do not have family history, being the first degree or the second degree parenting, they don't need the genetic test. What they need for screening is just mammography. Clinical screening, there is no study that has showed that clinical screening, that it means that examine only the breast, is sufficient to tell the patient that you don't need to worry. You have to go for a imagery things like mammography or mammogram. So the genetic test is not for everybody. It's only reserved for those people that have family history of that kind of breast cancer. They are mostly reserved for those kind of people. Because if they are family first degree, that means it's 50-50%. They can get it. They already have the mutated genes that are already in their body. So those are the ones that are tested. But for the population general that do not have this family history or they are having other risk factors, only screening with mammographies are the most important thing that is done. That is done everywhere in the world. So we start with mammography, and if you don't have any clear evidence that the patient has nothing during after the mammography readings, then that is the time we go for echo mammaire. And the others, the MRIs, those ones they are left for treatment. They are not used for screening. They are left for treatment. So that is my answer to it. If someone has something to add to it, maybe the clinical students.
Yes, I wanted to buttress on what Malik was saying, like how to call it, like How to call it, patients will need genetic tests. That's why even concerning the how to call the screening, because the screening you have the clinical part and you have the paraclinical part. Like normally the patients that we normally use how to call use like mammography or echo mammography like for depistage. These are patients like normally like if you normally we do this like every 2 years in Morocco. Like normally it's done every 2 years because like the depistage is normally like done every 2 years. And but the thing is that it's like how to call it like, and it starts from at the age of like maybe 45 and above. You get it. But the thing is like how to call it, if you have patients like if they have a medical like history in the family, whereby like they have a family history of breast cancer and stuff like related like cancers, like normally we advise them to do their how to call it, their screening like earlier than 45, like maybe at the age of 40. But normally, like the debut stage of the screening part is normally done how to call like every 2 years, provided like the patient has no like a clinical part, like the patient has no symptom. But if the patient has like certain symptoms clinically, they have to go for screening direct. But I would just mean like if the patient has no symptoms or nothing, normally the screening like for it is normally done every 2 years. And but if the patient is like at the age of 45 and above, but if the patient is like how to call it, have a medical history, like the screening should be done like earlier, maybe at the age of 40 they should start doing screening like every 2 years.
Okay, to add to the genetic testing, first of all, before a genetic testing is done, you have to undergo genetic counseling. That is, this will determine whether you and your family are likely to have mutation of your gene, and it is recommended for people who have strong family history of breast cancer or even ovarian cancer, and a personal history of breast cancer, ovarian cancer, or fallopian tube cancer. It is also a recommendation to do genetic testing. The reason why we do genetic testing is because there are two genes responsible for cancer. Normally, these BRCA1 and BRCA2 genes help. They protect they protect you from getting cancer, certain cancers. But if there is a mutation, then they deviate from their roles to protect you from cancer. So you will get the cancer. So that is why we do genetic testing. So if you have a strong family history, and also if you have a personal history of ovarian cancer, fallopian tube cancer, then you have you should do genetic testing. I think.
Thank you so much for emphasizing on those points. I think they are really important, and I hope that the audience are really um, highlighting all of the points that we are mentioning and then trying to spread it as much as possible. So talking about screenings, you guys have mentioned screenings, so many aspects. So could you please tell us, the common screening that we can do in order to detect breast cancer? Fatmata or Omar?
Yeah, I can comment.
Yeah, Mr. Dia, if you can hear me.
Thanks so very much. The program is interesting. All right. For the aspect of the screening aspect, what we normally do, we have something we call depistage. So it's normally done every 2 years for, for certain category of women. So it is done by mammography, a machine we call mammography. So like it is the standard machine for depistage recommended globally. Then after the mammography, we have another machine called echography. So we also have an MRI. MRI also is normally recommended, but in a certain way. So for the mammography, what we normally do is it's not a difficult process. We have the patient placed by a technician, the radiology, or otherwise called the radiographer in English. He's the one. He or she will be the one to take the image of the particular patient. So in this image, what the doctor is interested in, I think, is the calcification. One of the things is the calcification divided into two. That is the macro calcification and the micro calcification. So the macro calcification, most of them are not they are not dangerous. They are due to aging of the arteries or the veins, or sometimes it can be caused by an injury caused long time ago on the breast. It can also be caused by an inflammation. So when under such circumstances, you may detect a macro calcification. Sinon, for micro calcification, they are tiny they are tiny masses, or that can be detected on the breast, uh, and they are dangerous. I think when we normally detect the microcalcification, we normally order for a biopsy to ascertain whether they are benign or malignant. So that's where the mammography comes in. So the other thing the doctors looks for in a mammogram is the mass. That's where we talk about earlier the cyst and the fibroadenomas, etc. So when we detect a cyst or a mass, what we normally do is they refer the patient to do an echography to ascertain whether it is liquid in nature or solid. So when it is liquid in nature, too, you don't just leave the patient and go home. So what the doctor do is they normally aspirate the mass to remove to ascertain whether it is benign or once again malignant. So if not, if it is solid also, that's where the interest comes in. They may ask for further exams or, or do a biopsy again. So for the other thing they also look for is asymmetry, whether the breast has changed in size or position, different from the normal breast. So that's what they look for in a mammogram, and also the density. But the density, I think, for a mammogram, it will not be adequate to look for the density because of the nature of the breast. Uh, so I think for the density is either we use an echography or we go for MRI. But for MRI also they are this now call it MRI. It's normally recommended for people who normally have a family background of cancer, where your family is known for cancer. So because what we are running away from is you come and do an MRI, you know, due to the nature of the detailed nature of the MRI, you may find out you may give the doctor may read what we call false positive. So false positive is it may lead to unnecessary biopsies, etc. But then I think that those are the moments we normally use. For the scanner, it's normally done after detecting that it is a cancer. After ascertaining that it's a cancer, then we can do a scanner simulator. We call it scanner simulator for treatment planning, etc. So I think right now globally the machine we normally use is a mammogram, uh, for depistage, etc. Sometimes they normally use the two, mammogram and echography. I think that answers the question. If you have another one.
Well, I think we have to just know that when should the population go for screening? At what age should we start screening? You already explained what are the tools that we use for screening, but at what age should patients go for screening? Be in the general population or be in the population that already have a risk factor of or family history of breast cancer. So I will lead it to the other doctors to come up with those points. Dr. Aliu, Dr. Njai, when should patients go for screening? At what age should they go for screening?
As far as like the screening part is concerned, normally patients should start like doing the screen at the age of 45 and above. But if they have a family history of like breast cancer, this can be done earlier, maybe at the age of 40 or less. But normally it starts from the age of 45, and it should be done every 2 years, once every 2 years. And as far as the screening also is concerned, like the guy was saying, like mammography normally is used for screening. If you do mammography and we detect any abnormality, we can go to diagnostic materials like ultrasound. From ultrasound, then we can do biopsy to confirm. Biopsy is like the final exam that is going to confirm if there is a cancer cell or not. And we can use MRI OC for staging at some point, because cancer cells, like we have to stage them. They can be invasive or non-invasive. So we have a particular type of, how to call it, like staging that we can do, like stage 0, stage 1, stage 2, stage 4. So normally you can use MRI for staging, or exactly. So and the worst stage is like stage 4. Stage 4 normally is metastatic. So that is like, how to call it. In this way, it's like the cancer cells have spread to other tissues. And based on the staging, we can, like, how to call it, we can choose the type of treatment that we are going to use. So it's very important, like, to know that. But as far as the screening is concerned, it starts at the age of 45 in
So grosso modo, we are just saying that so patients that are less than 40 years, they can start their screening when they have a history of breast cancer. And patients that are from 40 years and above, then they can start their screening after 40 years to look for breast cancer, and after it can be repeated every 2 years. This is the American recommendation, the last recommendation on breast cancer. So the tools that we have in the Gambia, comparing into Morocco here, is a mammography. We have mammography in the Gambia. So clinically, if you go to a doctor and explain your problems to the doctor about lumps and all those things, it is obligatory for them to do a mammography. So you should not take the speech of anybody that you should go home. It is okay, I've examined your breast. No, you have to do your mammography so that we will not like do a late diagnosis of the problem. So that is very important to the population. So mammography is available. It's just like an X-ray. It's just like an X-ray. It's the X-ray of the breast. It's simple, and it is easy for the populations to do it. So when doctors detect certain problems, they can now further the examination to see what is going on. But what is needed is before 40 years and you have a history of breast cancer or ovary cancer, you have to go for screening. And even the doctor can propose a genetic test. If you don't have it, then you are in the category of those people that are 40, 45 years above. You should go for mammography that is systematic to detect early precoce lesions.
Hello, Mr. Mama. Okay. Thank you, our humble panelists, for those answers. I think we can move to the next question, which states, what are the choices of imaging and risks associated with mammogram, ultrasound, and MRI?
That question
That
will be
question
given
will
to
be
the
given to the
radiologist.
radiologist.
What is the risk of mammography and the risk of ultrasound and that of the others like scannings and that of MRI.
And that of MRI. Yes, hello. Can you hear me?
Yeah.
Yeah. Good. Thank you so very much once again. I think the question is asking the risks associated to the more in the diagnostic, right?
Yes.
Exactly.
Okay, all right. Normally, what we normally say, I mean, mammogram. If you look at the basics, the mammography is a machine that uses rayon X. So rayon X, they are radioactive substance. We call them the rayon ionizant. So that's I mean those are the materials or the substance the mammogram or the mammography use to scan the body. You know. Just like the scanner, the machine scanning, CT scan and radio standard. So the risks associated with rayon X, produced by the mammogram is that you know, the continuous usage of rayon X can cause cancer. So people are afraid that you know if you overdose, can cause cancer. Especially when you continue doing mammogram every time, especially at a younger age. We have what we call lesive secondaire. At some time it can harm you. But for ecography and this ecography, if you look at the basis, it is using what we call les ultrasonores. Donc, they are not harmful, and also MRI is not harmful to MRI. They use magnets. So the only one we are afraid of is the mammogram. But then when properly used, and not always, because sometimes we have this attitude. Me, I was a radiographer. I did techniques in the radio, and also also a physician. So what we normally do when you take an image and it is not properly taken, so normally we have this bad attitude of repeating the image. So it's not something that is good. So I think c'est une cuisine interne, mais quand même c'est pas une bonne chose. Uh, like, because you are overexposing the patient to rayons. Instead of treating or looking for treatments for the cancer, you are, you are, you are risking the patient to get cancer through the rayon X. I think that so far, to my knowledge, that's the only problem we have with the diagnostic. It's only the mammogram.
So that is right. When you have mammography, so besides it acts as the cumulated doses of the rayon X, that's why that is noted that people will used to do it at a distance every 2 years, so that to prevent patients from uh, rayon ionisant, because also it's a risk factor. So patients that are even going for radiotherapy, which uses ion risk, rayon X come like this, how to call it again, for the mammography, like the x-rays, they also have risk of developing breast cancer. So the practice, what is important is that the radiologs, the radio technicians, they are very good. They will make sure they will position the breast in a correct way, and they will take the pictures once. And if there is something they have a doubt, they will do with ultrasound. Ultrasounds, they are just sonors. They don't have any side effects, so that is not a big deal. And the MRIs also, it use magnetics. They have no side effects. The CT scan is only used when you have a diagnosis and they are looking for the spreading of the disease so that they can control it. But the mammography, that is the one that have side effects. But the side effects depends on cumulative doses. That means how frequent the patient is doing mammography. So once you start your screening, it is important to do it every 2 years, not every year, every 6 months. Some patients, you have to explain that to them also.
And also to add, according to research, they are saying that some people shouldn't do the MRI, that is the magnetic resonance imaging. Women like who are pregnant, because there's a risk of affecting their fetus, and also patients who have pacemakers installed in their bodies also are prevented from doing MRI, and people with who are recently plagued with metal of the blight protests also are prevented.
Well, you are right.
Are also,
Has to
are
say,
also
Emma.
yeah,
Okay,
also prevented, like these surgical devices are also
exactly,
prevented from doing
exactly.
MRI.
In fact,
Exactly.
MRI is not part of the screening tools. When you go to MRI, that means that there is something. That means that at least before going to MRI, normally it's echo mammaire, and the echo mammaire, they can do cytoponction or they can do a biopsy quelque part. MRI is not part of the tools for screening because the accessibility is very difficult, even in rich countries. So it is a tool that we don't use. We only use mammography coupled with echography if it's necessary. And if we are still having a doubt, we will do a biopsy or we will do a cytopunction to guide the diagnosis. Yeah, right. And for MRI, you should also take care of all devices that the patient may have. Cardiac pacemakers and all those things can be. But in pregnant women, MRI is not a big problem. It's not a big problem. It's just that if they have cardiac device like pacemakers or a resynchronization device in their heart, that is the time they would have those kind of problem, and MRI is not indicated. So if not, the screening is only based on mammography. That is the basic, and that is what we have in the Gambia, and we also have ultrasound. So an ultrasound also it depends on the practitioner, the one that is doing it. But at least the basic we have it in the Gambia, which is mammography.
Also to add something about the MRI, in fact, the MRI, like as Malik was saying, like it's not really contraindicated that it is not really against like in pregnant women. Normally, the time that we are scared is like maybe during the period of organogenesis. It's like when the organs of the baby is been formed. Like maybe it's like from the first 6 to 8 weeks. But after that, like the risks are very minimal. So I think it will not be a problem to use MRI if there is an indication to use it. But normally we most scared like during the organogenesis, like from the first 6 to 8 weeks of pregnancy, when the organs of the baby have been formed. But like beyond that, there is if there's an indication really to use it, I'm sure like we can use it.
Yeah, I think one of the machines that we normally don't advise pregnant women is machines that emit rayon X, like the mammography, the scanner, etc., radio standard. But an MRI and this thing, echography, I mean, they are usually recommended for pregnant women, etc. But then, unless when the need arises and the doctor sees it necessary, to do a mammogram on the pregnant woman. Sometimes you normally take them back. You ask them if you are pregnant or not. If they say they are pregnant, they didn't see their period. We normally refer them back to the doctor. And if the doctor sees it necessary, to we have to do the mammography. Then they can come back. But it's the machine emitting rayon X that we are not we are afraid for pregnant women to use. To add on to what the other panelists just said.
Yeah, mammography in a pregnant woman is not an important uh, time to do breast cancer screening. It's after the pregnancy. You cannot expose a pregnant woman to Ryan X. So that is, I've never seen that. I've never seen an emergency in that unless the patient is diagnosed cancer before she gets pregnant. And those are rare cases. But it's not something that is very urgent. You can leave the parturient on after delivery, and then afterwards you can do screening. And you see, and here we are talking about maybe patients that are having family history, because patients that are already in their 40s or 50s, surely that they are not pregnant. So maybe it's something else if they say, but those people, but pregnant women is not an emergency. It's after delivery. Then after that, in that way, they can program for. So they don't need to be exposed in anything. There's no emergency for that, unless the disease has been diagnosed in them and treatment has to be done. That is the only time. And it is also complicated when you have pregnancy and you want to install chemotherapy and all of this immunotherapy. I think it doesn't go with pregnancy because it's very toxic for the body and for the baby also.
And to add something, like it's even very rare to see like a pregnant woman with breast cancer. It's very rare. Like normally, like it happens, but it's very rare to find a pregnant woman develop like breast cancer, because normally like pregnancy itself is like a factor that protects, like how to call it, like women from developing breast cancer.
We can go to the next question. I can see that there are many questions on the chat.
Yeah, definitely. We have so many questions. I'm so glad that you guys are mentioning all of these like side effects of the treatments, and these side effects are already something that the healthcare professional will pay attention to whenever a treatment option is to be taken. So it's like you don't have to worry, because at the end of the day, the medical practitioners and the radiologists, they will have to work together and then make sure like the best treatment is given at the right time. So the patient wouldn't have to be put in a worse situations or stuff like that. So it's a safe space to go for screening, and also to get to get the right to go to the hospital to get the right treatment at the right time, because the health professors will do their almost best to give you the best treatment that you need. So you don't have to worry about that. So we should also talk about self examination of breast cancer, because that is also very important, because sometimes you can detect you can prevent yourself getting the cancer to a stage where it will be difficult to treat. So we can also talk about self examination. If primary will be great, so that we can have it done in our houses or homes, and in our respective locations.
So
What was the question? Does anybody knows the question?
I think it's what the
Yeah,
self-breast examination.
self examination of breast cancer, because it's very important for people to know.
Okay. The self-breast examination. It is recommended to perform it maybe once in a month. Um, some research said that from after every 5 to 7 days, after your period, after your menstruation cycle, there are three positions in which you can self-examine yourself: by standing, by lying down, or some. The third one is some women prefer to do it in the shower because they feel like while they are taking bath, their breast is more tender. But it depends on the individual what is more comfortable to them. So for the lying down, um, which is um, for the lying down, you can do it at any at hello. When you lie down, your breast tissue it covers all your chest. So this is a recommended way to self-examine yourself. So what will you do first? You raise it and put your hand on your hip and do circular motions through all the areas of your breast. So it can be deep and superficial. And also, you should compare the two breasts, that is when standing up, so that you can know the abnormal and the normal. So for the standing, you can either raise your hand or it can be on your hips. So you can look for the changes in color, the size, and also if there is liquid coming out, that is blood or any type of fluid. So you can also look for dimples or inverted nipple in your body, in your breast.
I think it is clear. So self-examination, touch your breast. If you feel anything, then consult a doctor. Because it's very important to say this because the person knows himself better than the doctor. We are just what the patient feels. That is all what we take. We group it together to look for a syndrome or we look for a pathology. So the patient knows best. So it is the interest of everybody. Right. You should not say whether you have gone to school or you have not gone to school. Touching your breast, I think everybody touches his or her body down. So it's not something that is a taboo and all those things. You can touch your breast. If you feel something that is abnormal, then you can uh, go for consultation and ask the expertise or the doctors to help you know what is going on. In that case, they can do this screening very early for you and give you a correct response. So that is the main information to pass by. Anyway, you examine your breast is okay, but if you feel something that is not right, that is not that was not there, and you have been feeling it, then do not hesitate. Do not wait until this signs will start getting like accumulating and aggravating for you to go and consult a doctor. No, you have to be concerned about your health. And this I will say it for the Gambia. That is the problem. We have certain things, but we neglect it. We don't go to the hospital because we always consider hospital. If I go there, no, that is not a good idea. And it's also not a good idea to go to the pharmacy, start getting drugs to treat yourself. That is the worst thing. And right now, I will say it because we have like kidney disease in the country. Some of you people can be the cause of that because you taking auto medication, you don't know what you are taking because somebody else told you something. He's not a doctor. People are fond of that in our country. No, go and get the advice of a medical professional to tell you what is wrong with you. I think that is better before taking any medication, getting yourself into harm. I think the screening is very simple. They will give you a screening, and at the end of the day, they will give you a clear response of what is happening.
And also to add something, it's like the self-examination has two parts. That's what we call the first part is called inspection. Like you can inspect your own like breast. If you see any abnormality, like you should go and consult. The second part is what we call palpation, like palpation. You use your own hand. Like the breast is divided into like four quadrants, and you palpate it. If you feel like any abnormality, any lump or whatsoever, like you have to go and consult. Because Gambians have this issue, like probably like most times that if you don't have pain, like you don't go and consult. You can see something that is abnormal or touch something that's abnormal, but as far as it's not painful, it's okay. It's not like just forget it. And the moment that like a breast tissue like start to get like maybe if it starts getting painful and stuff like that, it means like the things has advanced a bit. So that is a notion that we have to be very careful about because Gambians are like as far as I don't have pain, there's no need for me to go and to see a doctor. And the moment that the pain already starts, like the thing is already late, and it can be very invasive at that point, and your chances of like survival and can be very slim. So as far as as soon as you detect anything by inspection or by palpation, it's like you should go and see a doctor.
And just to add, to do a summary of it, you should really be comfortable touching yourself, touching your breast. You should know what the normal is and what the abnormal is. So by touching and observing yourself, your breast regularly, maybe once a month, that will actually help you to know what the normal is. And in case if there is anything that goes wrong, you'll be able to detect the normal early, and then the treatment can start, or you seek medical attention.
Yeah, thank you so much. It's the conversation is getting interesting, and I'm really liking it. And sometimes in the Gambia we also have this social stigma, especially in women. So it's very very important that you pay really you pay close attention to your body and to your organs, and also consult medical personnel as soon as possible that you detect some abnormalities. It's very very important, and we really have to emphasize on this. So I hope the audience are really paying attention to this and also spread the message that we get from these health personnel so that the information can get to where we want it to get. So it's very important. By the way, we are running out of time and we have so many questions that we also want to do, especially about the myths that comes with breast cancer. But I will just have to go through some of the questions that has been raised by 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 the people watching us on Facebook. Someone is saying, what role can men play in supporting breast cancer patients in families, as well as contributing in spreading awareness about the disease? By the way, people have to know that men are not safe also. Men can also get breast cancer. So it's like it's in both gender, even though the percentage is high in women and men. But at the end of the day, we have to support each other. So if you can emphasize about the collective support we can do men and women to make sure like we get more awareness about breast cancer. It would be great.
Yeah. All right. Thank you. Can I come in?
Go
Hello.
ahead.
Yes, you can comment. Don't worry.
Good. Good. I mean, the question is what men can do, right, to support cancer patients.
Yeah, the question is
All right.
what what role can men play in supporting breast cancer patients in their families as well as contribute to spreading awareness about the disease?
Okay. All right. I think first of all, being it breast cancer or any other malady, sickness, you know, as responsible people like men in our society, what you can do in your family is, you support your patient. You know, if you cannot at least accompany, like go with the patient for diagnostic or for treatment, at least provide the mean, like for the person, like your wife or your sister or any other person involved. Let them be comfortable around you. Give them what they need, support them, because you know like helping them be stable mentally would also help, in the treatment process. But then it's unfortunate that some men, when the moment some of our spouse get certain diseases, we start running away. We cannot take care of them. You know, we prefer calling a third party, their mother or another person, to come and help them. But I don't think we should continue doing that. We should continue being supportive to our women, like they normally do to us, vice versa. I think the support is very important. And like Mama said too, men are not exempted to this disease. It can happen to us, even though it is very minimal, but it's a possible.
Yeah, that is very clear. I think the psychological part is very important. So those patients affected by breast cancer, the families should come together and help them. It's not only psychologically but also financially. As we know, in the Gambia, most of these treatments we don't have it there, so it is rather challenging, like providing the financial assistance for those people. So before going to that end, I think it should be the responsibility of every household, as the leader of the family, as a man in the house. You should educate the family. You should help to educate your wife, educate your children, especially the female ones, and also support them to follow this kind of programs, so that they will be aware of their health, because very important. And it's like in our country is somehow a taboo. They don't want to talk about any sexual stuff in the house. I think we have passed those generations. We have to discuss them, because some of our children are suffering from certain problems, but they cannot openly speak to the family. That's why sometimes we discover this disease lately. So that environment should be there. I think we should start it from, we should start it to practice those kind of things, explain to our families, explain to our mothers and all those things, so that they will know about these things exist. And there are certain things it is necessary to do it, because prevention is better than cure. Since that we have limited resources of health in the country, we should go for prevention. We should always go for prevention. We should, people in the Gambia, that is their problem. Even if you have small, nowadays health is not free and is nowhere free, but at least even a small dollar that you will put in your health is something, is important. So screening is very important. Do it early, and you will save yourself and you will save your family. And those that have unfortunately the problem of breast cancer, I know that in the Gambia they have certain societies that used to help these patients to go for further treatment either in Dakar or abroad. They have an association. I don't know which one, but I'm sure of it. They have it there to help patients that have advanced disease to go to other countries for treatment. But that is another discussion. The Gambia also, we have to form more doctors, like gynecologists, because there is two part of it, is gynecologists and obstetrics. The gynecology part is the ones dealing with the cancers, and you have oncologs. We don't have them in the Gambia, and it is very important nowadays. The emerging diseases are cancer disease, and if we don't have these specialists in the country, that means that we are going nowhere. That means that even if we diagnose patients, we cannot do anything for them, and that is really really sad, that you diagnose a patient with something and you cannot do nothing for the patient, because some of the majority of them do not have the means to go outside for treatment. So that's why the awareness, like sensitizing the population, is very important, so that they can start precously, so that at the end of the day they will avoid these terminal stages or stages that are very difficult, needing a lot of doctors, specialized doctors, to take care of them.
Uh, Thank you to our panelists for that answer. I think we move to the next question, which reads, in a country like the Gambia, where our health system is dormant and backward in addition to the recent occurrences in the country's healthcare sectors, do you think the population will be confident to attend to the clinical trials where the first, if not the only test conducted on patients is the test for malaria, the presence of Plasmodium parasite? And how will you advise such a population into trusting the healthcare system and to attend to clinical trials when necessary? By Idris Hassan.
Hey, he asked a very interesting question. Hey, that is the question for everybody. That is the debate for every time that I meet my colleagues, I meet Aliu. Always, where do we stand? That is the problem. The problem is that doctors have to gain the confidence of the population. These are the kind of programs that they should be projecting in our country. You want to convince patients, you have to sensitize them. If you don't sensitize the population, then how would they know that these things are existing? How would they know the severity of these diseases? That is the number one problem. It's true that we already have problems, and now to at least like to for the population to have confidence in you, you have to do something. And these are the programs. Nowadays, what do we do in this world? The world we see nowadays, we will fund programs that are having nothing to do with health, like programs that will have to do with fun, but they will not fund programs that will have to do with health. Just a simple funding to sensitize the population. They won't. And if you don't do that, people will not think that these kind of diseases are serious. They will not take anything serious. They will not know what is happening. And once you sensitize the population, that is phase one. Phase two is looking at the health sector. Do we have the means? Have we created some little room for this kind, like patient having a special place, like health centers to go for screening? Like in every region of the Gambia, you should have health centers, and these health centers should be organizing screening programs for breast cancer every time in a year, so that patients will come, and they should sensitize it in the media. Nowadays, everybody is using telephone, is using these media gadgets. They will, but at least when you are sensitizing people, just use a small time of it. Just say what is important about it, to show that it's a deadly disease. So do not come and blame anybody. Now you have been sensitized. The population now, they depend on the doctors to give them that confidence. Most of the patients in the Gambia, when you say they go and see a doctor, but I doubt they see doctors, because sometimes someone will give them an advice that I don't think a doctor will do so. Yeah, some of them they say that it's a doctor advice. I don't think so. Most of them I say that you are doing something. I don't know what is that is what is happening. I don't know what is it's on the ground. I'm not there in with them, but they don't get correct advices. Some people just hear something from certain places. That is the good advice, but they should got the doctor's advice. But the way to do that is to do this kind of programs. We have to sensitize the population. We have to tell the population the means we have to make these things work. If not, the population will never have confidence in us. And that is the problem. The whole sector have to come together to see how to work with the population. But if we cannot do that, then we are not going anywhere. If you cannot do that, we are not going anywhere. And that is very sad. Our health sector is rather going back instead of going forward. That is going back instead of, we need support, and everybody. And I think that it's not only doctors or the government. Everybody should come, work hand in hand to make it work for us. Some people have means to go outside for treatment, but some people they don't have those means. So we have to be conscious of our health sector. But I don't think people
the health sector, they take it seriously. Unless you are sick, that is the time you will start complaining that the health sector, there is not this, there is not that. Because even routine exams, people don't want to do it, even if it costs them $5, but they would like to go to do parties and all those things and spend money. That is the nature of the Gambia right now. They think that health is has to be free. Where did you see that? Nowhere. You go to America, health is not free, my friend. You have to work for it, and you have the social security. You are paying for the social security. You are not giving that as free. You go to Europe, it's the same thing. So we have to do something for ourselves if we want to help ourselves. The population, you cannot just be blaming the doctors and we don't have confidence in doctors. You will not have confidence in doctors if the doctors are not really funded, given the tools to work with, so that they can come with outcomes that will tell them, we have discovered this, these are the kind of treatment that we have tested in the population, and now it is working very well. We don't have it. So that is the problem. So we have to come with that. In medicine nowadays, if you look at the medical sector in other countries developing, because there is investment in it. But for us, we don't invest anything. And the small portion given by the government, that cannot do anything. That's what we have to know. So I think this is the thing that everybody has to be aware of and start to work towards it.
Thank you, Dr. Malik, for that. Mr. Cisse, do you have anything to say? Oh,
Yeah,
Mr.
just
Kiba.
to buttress on what Malik said, like Malik already said it all. It's like how to call it. Like it's important to do what we like to sensitize the public, because in a country whereby not many people have like how to call it like the means to go for further type of treatments, and in a country whereby your treatment options are very limited, it's better for you to be able to like how to call it to be sensitized and do what we call prevention, because prevention is better than cure. Because if certain like how to call it cancer treatments like radiotherapy and chemotherapy, they might not be available in the Gambia and they can be very costly. So how many patients have the means to go to Senegal or other places? You get it. So I think sensitizing people and let them know like their health is important, because if you're not healthy, like that's the and Gambians, for like as far as health is concerned, no, it's like if I have something very serious, I have a serious pain or something that I cannot move, like I'm impotent. That's the time that they go and see a doctor and stuff like that. But they should be like we should be more cautious about like our health. I guess that is like so important to know. And Malik said it, like the doctors too, they don't have the resources to work with. Even if you go there, they're gonna just they're just gonna use maybe clinical like knowledge to help you, but they don't have certain tests and examinations to do for you. So sometimes they will send you home and just give you certain type of treatment, not because of they want to, but they don't have other means to do further examinations and tests. So it's up to patients, to be very like to take their health, very like very serious, and to be sensitizing like people, and to be doing like all the screenings as much as early as possible.
Thank you, Mr. Cisse. And Mr. Ba, if you don't have anything to say, I can proceed to the next person.
Yeah, just apart from what they all said here, I think the other aspect is like or any other student, studying outside. Whatever you are doing, do it to the best of your ability. And when you are done, try to have that patriotism in you. When offered the opportunity to go and serve your country. You know, like we need radiologists, like those who can read images, in that country. We need, radiotherapist, we need oncolog, we need etc. etc. Everything is needed in that country. So apart from the tools, to the human resources is required, to move the health sector. But the tools to they are the basic. Like you cannot call someone without providing the environment for the person to work. Like the echographies, the mammographies. Normally what we normally see in other countries, we have what we call caravan mobile. Like every year, or every 2 months or 3 months, they normally organize caravan mobiles. But in the Gambia, even if you organize that, who is going to sponsor it? It's going to be difficult, and one or two doctors cannot sponsor such an adventure. So it's very difficult. We need support. It's either the NGOs or the government should provide at least those equipments for the doctors to work, and also the physician, the nurses, everyone.
Mm, thank you so much. I think everybody can attest that, like the conversation is very interesting right now. And I just want to comment on this because in the Gambia, one of the most constraint that we face right now is preventive treatment. Because we mentioned about exercising. Even exercising for somebody to be having regular exercise is very difficult. Sometimes they don't prioritize our health. Especially when it comes to preventive treatments, because if the resources are limited, if the health facilities are limited, the one of the most important thing to do is to prevent yourself from getting it. And we have already mentioned some of the preventive means that we can use. So it's better for everybody to pay attention to this, so that you try to prevent yourself from getting certain certain uh, certain infections or disease, or like breast cancer, so that at the end of the day would minimize the rate of breast cancer, and also the rate of also consultation is very important. Gambia, we barely do consultations. We don't go to the hospital unless we are very, very, very sick, and normally you have to go to the hospital at least every 3 months. You have to go, so that you can get proper consultations to know to detect some of the things that are abnormal and some of the things that are normal. It's very important to pay attention to this. you know these are things that we really have to put into consideration. So, talking about treatments, we have limited resources, and we also have limited treatment options. What are some of the treatment options that we have in the Gambia? If you can highlight on that before we end, because we are running out of time. And I think the most important question from the comment section has been read. So, if you can highlight the treatment options before we move to the conclusion part of the panel discussion, because we have a lot of things to say, but all of this is confined in a specific time. So, you can highlight about the treatment options.
So the treatment we have globally, we have surgery, we have chemotherapy, we have radiotherapy, and we have the new ones that are coming now with a molecule called trastuzumab, that is immunotherapy. But what we have in the Gambia, I don't know. And if we have, maybe it's chemotherapy, because you have to have like a panel of doctors so that they will be doing a discussion to know what is the best treatment, what kind of cancer the patient has, and what is the best treatment to give out. Maybe if we have at the limit, what we have is chemotherapy and maybe surgery. And these are surgery that means like localized cancer or even spread cancer. Maybe they can remove the breast, that is tumorectomy or mastectomy. That's what we go do in the Gambia. Chemotherapy, maybe it is present but limited. The molecules that we use is anthracycline, but it is very cardiotoxic. So you need other doctors to come in so that they can help in when the treatment is going on. And that is very heavy, but I don't know whether they have it in the Gambia. Maybe they have it. But for radiotherapy, I don't think we have it. We don't have radiotherapy. Radiotherapy, want to do, you have to go to Senegal to do it. Immunotherapy, I don't know whether it is there, but these are the basic treatment that are given. It depends on the stage of the cancer and it's spread into other organs. So these are the general treatment that we have for the breast cancer. So the most important one is anthracycline. It is very good. It's a molecule that we use, a chemotherapeutic molecule that we use in even localized or spread cancer. So it has a good result. But the problem of this molecule is that it's having a high rate of cardiotoxicity. So it's just like giving it to patient is trying to kill the patient. So, but if you have experts that are working with the patient and the doctors that are treating, they can do this preventive cardiotoxicity at the end of the day. But these are the basic treatment we have for the cancer. If it is localized, we will have to go for mastectomy and remove the ganglions, because some of them they already start spreading to the lymphatic regions. And if not, is the chemotherapy. If it is advanced, the chemotherapy or radiotherapy. Radiotherapy is mostly to reduce the type of and the volume of the cancer. And some of times they used to talk about the inflammations, some of these cells that will block the process of proliferation. That is this immunotherapy. So what we have in the Gambia, I don't know, but I know that they will have at least the chemotherapy. They can do the diagnosis and like start chemotherapy. Maybe if things get out of hand, maybe they have an association to help patients to go outside for over treatment. So this is the necessity to tell all the colleagues that are here. let's try and do a specialization. Medicine is advanced nowadays. So after our general practitioner, we have to do a specialization so that at the end of the day, we can come back to the country and do something better. Let me tell you something. Breast cancer nowadays, the death rate is reducing because of the treatment we have, and the prognostics is getting better. So it's just that we need the tools to work with and the expertise in the country to make it work.
Just to add on what Malik said, we can also have what we call like or hormonotherapy, like in the type of treatment that's where we use certain like how to call it, like hormones, like we use certain type of treatment like we call hormonotherapy. It's like this because if you are lucky, like some patients can have breast cancer, and if they have breast cancer, if they have is like if they have positive like receptors, either estrogen, progesterone, or what we call the HER2 receptor, like it's a human epidermal common growth factor receptor. Like if these patients are lucky that they have these receptors, in their breast cancer like cells, we can use certain like immunotherapy, like to block, like to block how to call it, like we are going to block or inhibit like these receptors, and they will no longer be able to like, like how to call it, promote like the development of this breast cancer. So if you can also have like hormonotherapy, and as far as chemotherapy too is concerned, Dr. Malik said like chemotherapy have that in Gambia, but it also has its side effects. Like people that are undergoing like chemotherapy, they can have what we call pancytopenia. It's like they can have what we call anemia. They can have infection, or they can have clotting issues. It's like when they're wounded, they can have clotting issues. But these are things that you have to explain to the patients, and they'll be aware of it. And and other maybe treatment like prevention, like or prophylaxis can be given, to prevent all those things. They can also have like loss of hair, due to chemotherapy, because chemotherapy is more like a systemic type of treatment. It doesn't only localize like the tumor cells, but it attacks all cells that have the high rate of regeneration, like the cells of the hair, the skin cells, and and your bone marrow cells. So that's why like chemotherapy is much more like it's a more like a systemic type of treatment. And normally we use chemotherapy like in stage 4 cancers. Like normally we use when this cancer is so like it has already metastasized to other organs. That's when we use chemotherapy. As Malik said, we can also use radiotherapy. Like radiotherapy is normally used maybe to reduce the tumor, because the tumor, if there's a certain protocol, like if the tumor is it has certain size, we cannot operate, we cannot do surgery on that type of tumor. You have to reduce it. We have what we call radiotherapy neoadjuvant. It's like we are going to reduce the tide to a how to call it, the size to a reasonable size that then the how do you call it, the surgeons will be able to operate. And sometimes you can even do after the surgery, you can also do radiotherapy. How do you call it, after the surgery, to also like clear, like if there's any cells that are left here and there. So these are and we also have other treatments, as you already mentioned, immunotherapy and all that kind of stuff. But I think in Gambia, to be honest, I don't even know like the treatment options that we normally have in Gambia. But that is it. So thank you.
Yeah, I was told that in Ghana they do surgery and chemotherapy, but radiotherapy it's not available in the Gambia. So that just surgery or chemotherapy. And for
Yeah,
the
exactly.
side
Just
effects,
to Fatima. Yeah, we only have chemotherapy and surgery in the Gambia.
and
That's true.
surgery, not radiotherapy.
Yeah,
And
and for radiotherapy is, I think we are yet to have it. We need a lot of experts
yes,
before we can have that. And a lot of funding too, because it involves a lot of heavy machines or expensive ones, from the
mhm,
electors, the scan diagnostic machines, simulator, and for accelerators, we need a lot of funding. But
yeah,
we do have them in Senegal. Radiotherapy do exist in Senegal, and it is in different forms. We have the chemotherapy, radiotherapy externe. We have the BNCT, etc. So everything is it's involved. It's not a painful treatment procedure. It just involves the patient to lie down under a machine. So the only thing you may feel some difficulties of moving, because it involves fixing you at a specific position for a particular period of time. Uh, so it's not painful, and also it's rapid.
yes. And to add to that, like for cancer, the treatment of cancer, it's not just um, one doctor. It involves multidisciplinary team that will come together, discuss, and make a decision on what is the way forward to do the treatment. And also, the patient has to be well informed about the treatment, the side effects, and later on, what he has to do, the checkups after treatment, and all of that. So most of these patients, they do get scared, like they do get stigmatized. They will be afraid. The concept they will have is, am I going to is my hair, am I going to lose my hair? Like some people are do get scared of that. And also we have these side effects like vomiting, having nausea, blood clots. These are all side effects. And also numbness. You can't even feel, um, you can't even, maybe when you put your hand under your armpit, you can't even feel it. Like it's like you're being paralyzed. Some of these are some of the effects of the treatment of breast cancer. And also swelling of the lymph nodes. It can be palpable, it can be touched. Yes, and also reduction of the white blood cells, because for chemo, when you use chemotherapy, it invades, it spreads out. It can be taken by pills or intravenous. So it invades other parts of the body. So it reduces the quality or the amount of white blood cells also in the body. Thank you.
So, on general, I will just advise and I will just tell all the Gambian students that are in the medical part, especially the clinical part, I would just like to tell you that you have to do better. I know you are doing your best. Yeah, yeah, you're getting good marks. Yeah, yeah, really advancing in the medicine. But let us have more specialists so that we can go back to the Gambia to have this team that we can discuss about diseases and a way of doing it. And since we have something, we have a very vital tool right now. Since that Senegal is a neighboring country and they have this sound oncology, so most of us that are speaking French will be easier to put like the medical report of a patient to refer the patient for more treatment. So I think that is very important. So we have to use this talent that we have, the French talent we have, to be able to communicate. And since Senegal is much more advanced, they used to have like Mission Française that used to come to Senegal and do certain treatment for patients. When I was in the Gambia, I even discussed with part of cardiology, heart specialists, so about how to do this kind of things so that we can collaborate with them and also help patients. For the meantime, that having more doctors to come into the Gambia to have our own stuff. So we have to try and collaborate with them so that we can help patients, so that we can have good outcomes at the end of the day.
And also to add, like earlier on, Omar said that we have to be patriotic. So we are the change. We have to actually try to go back to the Gambia and make these changes, because we cannot just sit here and then expect changes in the country. We, with the knowledge that we have to go back there, form a team, and try to improve these health problems in the Gambia too.
Exactly, that is true. We have to go back to their countries. If not, it is our country is doomed. So we are the future of the country. We have to go back and try to see how we can come with. We have good ideas, though, so we can come with better things and make the country go forward and help the doctors that are already there. There, I will just tell them bravo because they are doing their best. Sometimes you go to the hospital and see how they are working with the limited tools they have. I can just tell them that they are doing extraordinary stuff, because if you bring a white man to that place, the white one will not put on the coat to examine the patient because there is nothing to hope for. So they are doing their level best. It is the time for the population to come out and give them support and stop denigrating your own doctors, because this is the problem of black people. We
Mhm.
always look down on ourselves. Do not think that a white person knows better than a black, because nowadays if you look at Europe and look at America, all the doctors are foreign doctors. They are not even doctors of their own country, and they are doing marvelous in those countries because they are provided with the tools to work with. So when your doctors come back to your country, you have to support them. If you don't support them, then it is your own doom. You have to support them, push them forward, like what is happening here in Morocco. In 20 years back, We had French people here studying, doing all the medical stuff here as the doctors and the professors. But with time, you can see that it's only Arabs that are doing it. That means that they have really invested there in their country. So let us emulate that and invest in our country. And I hope, inshallah, things will come out great.
Inshallah.
Definitely, when it comes to health, like it's a collective thing. So there is nothing like you know, because it's health too. It has to be collective things. Everybody have to contribute, their little things that they have in order to make sure like the health sector moves to where we want it to get. So I think from this panel discussion, people will try to be more informed about what is going on about breast cancer. Even though the rate is decreasing, but we need a nation or a world where there would be no breast cancer. So at the end of the day, that is why we're raising as many awareness as possible. So we are running out of. I think we already elapsed the time, so we can just go to talk about the final message that we will give, and from there we can end the discussion. I know it's been interesting and people have learned a lot, and I hope that this session reach as many audience as possible so that they can watch and rewatch it every time to get a better information of everything that we discuss. So, Mr. Albert, well, now we move into the final part of the panel discussions. If you have final message that you can say, the panelists also, Mr. Dr. Malik, Fatimata, feel free to, send to talk about your final message. Yeah.
Yeah, generally, what I want to say is like I think Gambians just need to be more sensitized about their health. They need to take their health much more serious. Because I feel like we are a bit like ignorant about our health. So generally, I think people just need to take more caution about their health. Because if you're not healthy, you can't perform like in any aspect of your life like correctly or normally. So it's important that we try to take care of our health. And Gambian youths too, we have this sedentary lifestyle, and it's affecting like the youths and even elderly people. People are eating certain type of diets and they are not exercising and stuff like that, and it's causing like so many other issues and problems. So, sometimes you have a colleague of yours who will call you from Gambia and tell you, I have this problem, or I have a family member who has this and that and stuff like that. Just some of these things can be prevented if people are, being more active, exercising, taking care of their health. Because you run 2 to 3 times a week, watch the type of food that you eat and stuff like that. It's very important, and people to like how to call it like eating late too, because eating like before just going to bedtime, it's very risky to our health. And Gambians have this issue, and most of them will call you, they will complain about I have reflux, and stuff like that. Have this acid coming to my, how to call it, like up my esophagus and stuff like that. Some of them have ulcers, but some of them it's not the ulcer. It's just because of they have a bad time of eating. You should not eat just before going to bed, because that is a time that your body is using your resources, to help you, to regenerate certain cells and stuff like that. So it's like people should be very careful. Like they should be sensitized about all these things, and they should be awareness should be created not only in breast cancer but other related cancers or other related like diseases like so to like digestive diseases. That what people should be doing, and people should be much more cautious about, because you see an ulcer patient, they tell you, okay, don't eat this, don't eat that, and that is going to affect you, but still now you just keep doing it, and your ulcers will never heal, and you start complaining, I've gone to the doctor, they give me this medication, but I'm not getting any better. You're not getting any better, and they're telling you stay away from this thing, but you're not doing that. So I think people should be try to adhere to things that will help them, because health is very important, it's key.
Just say breast cancer is scary, so people should take it serious, and the that is for the population. So go and ask your doctor if you have some certain issues. Go and look for medical help. And for the medical practitioner, be open to patients, listen to them, not only the pathological part, but the psychological part that will make the trust between you and your patient and the bond. It will make it much more stronger. You have to listen to them so that you can advise them and see how to help them. That is very important. The bond between patient and that of his doctors, and also the doctors that are there should feel free. As I used to say, medicine is a domain that you will not say that you are the one that have all the knowledge. No one knows. We are still learning. If you have issues, you have your fellow colleagues, do not hesitate to go and discuss with them the kind of disease you think of, how to detect it, and how to come out with a possible solution. That is it. Nobody is big in medicine. Nobody knows nothing. So we are all learning. So in this way we are learning, we can help patient better. Let us always put ourselves in the patient's shoe so that we know how to help them best. So that is the message I'm transmitting to my colleagues. And the for the population, you have to respect your doctors. You have to give them all the information they need to work with you. Do not hesitate to tell them anything because they base on that information to look for what is wrong with you. So do not hesitate to go to the hospital, and do not take the negative impact that if you go to the hospital, this and this will happen, because always Gambians are afraid that you will tell them that they have this disease. I used to tell them that it's better to know you have this problem and that can be treated than you wait until that is the problem that will kill you. And it will not kill you alone, it will kill all your family. Because at the end of the day, you will be tormenting your own family, because at the end of the day, they will not even have the means to take care of you. But imagine if you have gone early, they will be able to set a program to help you out. So do not neglect your symptoms. Go and consult. You have free health centers. Go and consult. And if they ask you any small thing, if you cannot even do it, you can even convey your social problem with the doctor, and they will see whether they have social assistants there to help you, or an association to help you out. And the last thing is to thank everybody that is on the panel. You are really brilliant. You have a lot of notions, and I would love to work with you when I go back to the Gambia. And that is the thing. This is the
Inshallah.
family. I always want to say this is the family. We have to work together to make our country better. Yes, going to someone's country and staying there hiding does not make you nobody. You will never advance. Going back to your country and doing something for your population is something that you have to shout for. That is the thing. So let's try our level best. When we go back, we help each other. Don't look at, let us not put jealousy and although we are all Gambians. Difference of ethnics, we put it aside. We are all Gambians. Let's work together and make our country proud. That is the only information. I want Gambians to stop all this tribalism problem, all these things. We are all Gambians. We have to work for our country. If our country is good, we are the one that will love it first before other people. So if you want people to love your country, you have to love your country first. So I'm very happy this kind of discussion. And if you have any other discussion, I'll be happy to participate with my small knowledge. I can give what I know. Thank you very much.
Okay.
All right. Thank you, Mr. Malik, Dr. Malik, and Ali, and Fatimata, and to all the organizers of this great program, the host, Mohammad Jassi and Albert. We are really grateful, and I have no doubt that the panelists have learned a lot from each other. The audience too do learn a lot from the panelists. So what I want say is that we should try and work together, like Malik said, as a team. Tomorrow when we go back home, we can at least see how best we can solve our problems in the Gambia, especially the health problem. The other issue is I want to plead to Gasam, like the association, if they can help us not to wait until October. Every October we have these kind of programs. The health is very important. So if we have programs like this, even it's not cancer related, we can invite our medical doctors. They can come and talk about the health, make short videos, share them with our communities. I think that's going to be great, and I will advise that we do that, every time possible. And thanks so very much to every participant here present.
Thank you. Thank you, Omar. I would like to advise the people that we should not neglect the people that are battling with cancer. We should support them emotionally, financially, because these people that have cancer, sometimes they feel like life is unfair to them. So we should not neglect them. We should support them. Go with them when they are going to when they are having appointment, because early detection, like they say, saves lives. And also to add to it is having a quality and better lifestyle. We have to stop smoking. Of the treatment of cancer, early detection can save lives. And also to add to it is having a quality and better lifestyle. We have to stop smoking, the alcohol drinking, the lack of exercise. These are all factors that can cause that can lead to cancer. So we have to come
Thank you so much, guys. Thank you so much for thank you so much once again, guys, for the educative discussion that has been going on for about like 2 hours now. And I think some of the most common questions have been answered, and some of the most important things that we need to know have been addressed. And even some of the most important things that are not related to breast cancer has been addressed right now. So I believe we as the future leaders of the Gambia and future leaders of Africa and future leaders of the world, we trying our level best, to raise awareness and also to, share the little things that we can. So I hope the audience have also learned a lot from this session. So right now we almost done with the panel discussion. Omar mentioned that we need to be having more health platform like this, and I hope the executive will really pay attention to this and also try to get like more health platform like this so that we can address so many issues. When it comes to health, is something that is very wide. We have so many things that we need to discuss, especially Gambia. The health sector is you know really lacking behind, and together with some of the little things that we do, like having more health platform, it will really help. Like it will really help in one way or the other. So I hope the executive will really pay attention to this and help us to get more platforms like this. So without any other things, I think, Mr. Albert, you can go ahead and end the program if
Okay,
all is said and done.
first of all, I just want to say a big thank you to all the panelists for the wonderful thing you have done so far. We really learn a lot from you. And of course, the media team, thank you also. And to the viewers, we also thank you. I believe our panelists have said it all. Together we can fight this cancer, and together we can make our country proud of us. As one of the panelists said, or almost all of them, we need to go back and do this thing together for the Gambia, our homeland. Therefore, we all need to go and make progress within our country. I therefore say, or I therefore conclude this meeting. Thank you all for the viewers, and thank you for the panelists for your time, your energy, and of course, the most importantly, the knowledge you have given us. We thank you all.